Move on to the next session, and I welcome back also our participants online. And I have here on stage our colleagues Sarah from the NHS England that you heard this morning presenting. Welcome back, Sarah. James Dixon from Newcastle Hospitals, Jonathan Groom, Barts Health NHS Trust, and that's it. We're ready. And Oliver, sorry, I went in order. And Oliver Bisazza, our board member, who's also from MedTech Europe. Welcome, Oliver. I went in order and I missed it. Okay, so let's get started with our session on the future of healthcare decarbonisation. I will sit next to you as I'm asking a bit of questions to everyone. And I'd like to start, well, women first. I'd like to start with Sarah. Also hearing what you presented this morning and drawing on your dual perspective from NHS and international experience, you were talking about the collaboration and so on. What do you see as the single major governance barrier hindering the achievement of national climate targets? And what is a potential solution to these barriers?
Okay, I'm going to be the annoying person. You asked for one, I'm going to answer with two. But if I think of where I am at international level, if I look up at the international scene and at our governments, actually, I think one thing that is difficult in terms of governance is if you look at the Paris Agreement, if you look at what governments have committed to, they look at their territorial emissions. And as a health system, when we look at our climate impact more generally, we know that a lot of our impact is on our indirect emissions and what happens in the supply chain. And so sometimes it's difficult on those international discussions or governmental discussions to have that conversation, because actually those emissions happen outside of the actual geographies. And then if I look at the national work and at the systems we work with, I think going back to what I mentioned this morning, it's the risk of fragmentation. It's the risk of having one national team doing some good work and then some team on the ground doing great work and the two not communicating. Some research teams also, doing great work, but not necessarily informing action or policy. And so it's really how we bring all of those people together. And, that's sort of what we've tried to do with having green plans that embed the local specificities, but also follow national practice. It's also important to recognize what expertise needs to be centralized. And so we're very lucky, and when I compare to other health systems, to have quite good data centrally. I know not everyone would agree, but I can tell you compared to other countries, we've got pretty good data. And being able to have built a certain infrastructures with KPIs that then, all trusts can rely on to look at their progress, or primary care practices. And reversely, there are things that actually are really well done on the ground, testing, piloting, showing the evidence, generating, the case for change, the business cases, so that then we can scale up. So it's really having this positive loop, which can be really messy and fragmented, but which can also be turned in a sort of positive cycle, so that the experience on the ground and the research inform the policy, and then the policy also brings the expertise into what we're doing routinely.
Okay, thank you. So you mentioned the work on the ground. So I will move to James and hear more from your perspective on the what that you're doing in Newcastle. What is the one structural handbrake preventing you from executing the national policies that we heard from Sarah earlier, and also the scaling that she was mentioning? It's a sort of loop.
Yeah, it's hard to pick one, but if I was going to pick one, I would say government funding for decarbonising the heat and power we have in hospitals. So in simple terms, we're heavily relying on fossil fuels. The UK moved from coal-based power a long time ago to gas, great for clean air in that initial touch and good for carbon, but we're really still relying on that. There was great government funding for the public sector decarbonisation scheme. That's no longer available. So that is one of the main structural barriers, I would say. We've had huge improvements in clinical care. You heard nationally, we've had over 60% reduction in anaesthetic gases. We've halved our carbon footprint for travel. Waste, we dispose of less than 2% at the disposal end of the hierarchy, but our energy emissions are still so heavily reliant on fossil fuels. So that would be the main structural barrier, and that would scale beyond me. So that's, the Newcastle problem. It's also any hospital that has a reliance on fossil fuels in the UK.
Okay, thank you. And moving on to Oliver, James is dealing with localized trust frameworks, but the private sector faces an entirely different structural barrier, right? And we heard this morning about the tendering and the regulatory playbook varies significantly country by country. What specific frameworks do you need for health systems to help the private sector move faster?
Thank you, Ariana. So I represent the medical technology wing of the private sector, not the pharmaceutical one. So I'm speaking on behalf of medical devices. We are, to be very transparent, quite open about the fact that we have a long way to go. Compared to some other regulated industries, we were perhaps a little bit later to start our sustainability journey. And although there are always in some industries, front-runner companies who are ahead of the pack. Some of them are here today. There are plenty of smaller sort of family-run businesses which are struggling in this space, okay? So they do need help. They do need support. Probably the biggest one we need at a time like this is more harmonized requirements. We're living in a time when sustainability expectations are on the rise from all directions. Regulators, tendering authorities, civil society, even the workforces of the companies, right? If you want to attract and recruit and retain the best talent, you better be legitimately part of the solution. So those expectations are hitting the executives from all directions, and they want to respond. But what keeps them awake at night is knowing which of these expectations do I actually need to go after most urgently, and how do I cut through the noise of expectations that all sound similar, but are actually requesting the same thing in very subtly different ways. So perhaps most visibly that's happening in the tendering space, where green criteria are entering the tenders in public procurements. But we see a lot of variation in terms of not just what's requested, but how it's measured and reported. And because that's not a regulated space in the same way as EU legislation, for instance, you're actually navigating the subtly different requirements of different hospitals and different hospital groups. So if there's any opportunity to harmonize that, converge it in according to common standards or so forth, it could actually be, I believe, a strong incentive for the industry to go faster.
Yeah. Thank you. That's very good to hear. And I think it's also in line with what we're hearing a bit this morning about aggregating the demand and so on. So we heard, about the policy, the trust, and from Oliver in terms of supply chain. But we also heard this morning about clinical care and the choices the clinicians are making, how this can have an impact. So I will ask you to tell me, given the regulatory and governance barriers that Ada just mentioned, how can clinical regulation be reshaped so the clinicians see low carbon care as a component of patient safety and health?
I think we need to think about what it looks like on the shop floor at the moment. So be it in primary or secondary care, you could be a GP forced to deal with really high complexity within a 10-minute time window. You could be a surgeon facing a gargantuan waiting list. You could be an internal medic on the ward dealing with ever more complex patients with ever increasing demands. Add on to that, they're dealing with this in an ever lower resource setting with less in hot hospitals, as we'll see today. My phone is on fire today. People operating above 30 degrees in their operating theatres. We're then going to ask them to take on perceived additional risk. And our guidance isn't up to date in supporting it. So we need regulation and guidance that is relevant to that physician on the front line, to that healthcare worker on the front line, that is dynamic to the vast evidence base that exists out there. Now, we'll probably hear today about some of the regulations and guidance we see in the estate side of things, but we have, lots of regulations and guidance when it comes to the equipment that we use, and it's just not up to date. If you want to move to a reusable laryngoscope, for example, and you look at the IFU, the instruction for use document, and you don't want to send this critical piece of kit to the decontamination facility. You want to be able to reprocess it there and then. The way of doing that internally within the anesthetic room is not fit for purpose these days. It's not up to date with, modern day wipes that we have, for example. So we need to start getting up to date in terms of our regulation. We need to get up to date in terms of our IFUs for the equipment that we use. And we need to expect our clinicians to be able, we need to understand what we're demanding our clinicians to be able to do. We need to make it easier for them to make these decisions. So we need to update our guidance, and we need to make it easier for these clinicians to actually enact those changes. Because at the moment, our workforce is tired.
Yeah, we can imagine. Well, thank you for sharing that. So we heard about the barriers and challenges, not very easy ones to address. Moving on to the recommendations that our panel might have, to look at how we can improve the situation. A common barrier for national health system is, as we heard, executing climate action plans because they lack the dedicated sustainability and clinical leads on the ground. And that's especially true, outside of the UK, as we heard that you're lucky to have teams that work on this, but in other countries, it's not always the case. So Sarah, what is your advice on how to fund and formalize this green capacity paths?
I think advice would be a bit pretentious, so I will only say my observations and lessons learned. But so first of all, there needs to be a mandate, right? So I spoke this morning about the importance of having it embedded into legislation. It's a duty, and trusts have to have regard to that duty. We've also used, what we call hard levers, such as the NHS standard contract. The things that your hospital senior team will look at and will care about. It has to be core of this. It has to be core to your performance monitoring of your healthcare system. How you embed it in those things that then really matter to the people who make decisions on the ground. The second thing is making the business case for it. It's a bit crude, and it's a bit, but that's the reality. If you can show, James, you were talking about those big capital projects, and some of those projects have incredible return on investment, and we're starting to demonstrate that, and in a system that's very constrained, showing that, well, we're contributing to the country's commitment to net zero, but we're also saving money in constrained health systems. We're also potentially making clinicians' life easier. Again, you start getting a bit more interest. And then the third thing is probably be a bit creative in how you make that capacity. We've done some very interesting trials around hybrid roles, for example, for clinicians, where 1 day or 2 days during the week is dedicated to sustainability. And it means that you don't have to recruit a whole new person. It's also a really good retention aspect, because, some of the clinical staff are actually quite excited to work on something else. They want to continue to have a clinical practice. And, there's lots of people in the room, some of our clinical fellows and who actually love clinical practice, but also want to do other things. So I would say thinking creatively about how to create that extra capacity can also be a good way.
Okay, thank you for sharing these ideas. And so hearing also, Johnny, from you, the clinical perspective, and Sarah is suggesting how formalizing, these roles. But once they are in place, they must face clinical culture. And one of the questions we have for you is, how do we practically shift day-to-day clinical management, so these sustainability choices are integrated into the treatment plan? You talked about the challenges earlier, right?
So I think it's really important that we do fund roles to have experts and SMEs working on the shop floor that have that expertise from a sustainability perspective, that have that expertise of what it looks like to actually work as a healthcare worker. But anyone that signs on that dotted line to work for that hospital, this needs to be business as usual, a key performance indicator. What are you doing to lower the carbon emissions of the care that you're providing? It needs to be embedded into everything that everyone does, so that everyone starts to speak the same language. And in doing that, there needs to be a push on education so people actually understand. And with that, there also needs to be a drive against misinformation, which is incredibly rife. When we want to roll out, say, a reusable textile, you are fighting a culture of this is unsafe, this is unclean. And you can provide all of the evidence you want, but unless it's coming from a Royal College or someone that specific person respects, it's really, really hard to try and get that cultural buy-in on the shop floor. Now, we are lucky in some instances that we do have really solid guidelines in the UK. So we have our health technical memoranda and things like that. So I want to turn off my theatre ventilation out of hours. We're permitted to do that because NHS England has looked at the research, they've done the evidence, they've appraised the research and they've written the guidance. But the next step hasn't happened. James, you'll have read those HTMs, quite long, probably had a few bottles of wine doing it because you need one if you're going to read them. A surgeon is not going to read an HTM 0301, right? So there's a role for Royal College of Surgeons Bulletin, British Association of Orthopaedic Surgeons, to start helping to get that message across so that it's coming from a body that they trust. That can help drive things forward. So it's not just a key individual on the shop floor fighting a battle. This can be done nationally and internationally from these trusted bodies. And then we need to get the patients on board, the often forgotten patient at the end of the care that we're providing. So if we're running a gloves off campaign, or we're going to get rid of couch roll on all of our examination couches because, quite frankly, there's no evidence base for it and it's not providing safer care from an infection prevention control perspective, we need to find a way that we can explain that to patients in a way that is understanding and not showing that we're withholding care under the guise of trying to make the planet safer. Because when a patient comes in at their most vulnerable time, their focus is on their health and not on their acute health situation, as opposed to the immediate planetary situation. So we need to make it look like they're not a sacrificial lamb to a cause that we're all fighting for. We need to make it look as though this is actually the right, safe thing to do. So we need backup from trusted bodies. We need to support key decision makers on the ground, and we need to make sure our patients are joining that journey.
Yeah, and ensuring quality of care.
What's that?
Ensuring quality of
absolutely,
care. Yeah,
absolutely.
Yeah. Yeah, so that's interesting because also when we heard this morning about the Born Green Generation project and this new project we're doing also with the healthcare professional clinicians in the wards, and Joe and Frame, our colleague, was saying how they care about the health and safety of our patients. So I can hear here different themes. Depending who you're talking to, you need to use different recommendations and arguments to change the culture, right? And thinking of the supply chain, Oliver, we know that the data showing that supply chain accounts for up to over 90% of the medtech footprint. So have you done thinking with the sector, and what are the most critical systemic changes needed within the medical technology sector to unlock a path to net zero? Because that's what the buyers are asking for. Maybe not all of them, but we think is going to happen.
Indeed. So it's hard to generalize about the medical devices sector because it's so incredibly diverse from a materials point of view. It's practically any health product that's not a drug, so it could be made out of anything. But in general, you're right. We have put together a report last year about how the medtech industry can contribute to the decarbonisation of healthcare. And unlike many of our publications, which are just for members, we put it in the public domain. A, to be transparent about where we are, and B, to give some guidance to the many smaller companies out there which are not part of any industry association. And the findings, in some regards, are not that surprising. You're absolutely right that Scope 3, upstream supply chain, are the hardest areas to tackle. The supply chains for our raw materials and components are often very, very deep, very much global, very complex. And by the way, they're shifting right now with all the geopolitics going on in the world. So very, very tricky to manage that at a time of tariffs and conflict in the Middle East and so forth. That's ultimately where we need to get to, though, because in the short term, you have some relatively easy abatement levers that the industry should be seizing on, like completing the transition to renewable energy. That's comparatively easier. More circular product designs, a little bit harder, but at the end of the day, it's those Scope 3 emissions in the supply chain which are really hard to get at. So again, coming at that from the point of view of harmonization, saying all of our major customers in the procurement landscape want this and they want it in the same way, can help with that communication. But that's ultimately where we really do need collaboration, because the inconvenient truth is that while we are providing life-saving technologies and critical medical countermeasures for societies in need, oftentimes we are sourcing certain materials, electronics, etc., from faraway places, and we are simply not the biggest customer base for those big suppliers. I mean, our industry is never going to procure enough printed circuit boards and semiconductors as the manufacturers of these laptops or all these phones. So the commercial leverage we have to get cooperation from the upstream supply chain is much more limited. We need to make that case more on the grounds of what's right for people and the planet. So getting help from the public institutions would be good. But I don't claim to have all the answers there. That is actually the hardest and most urgent task. Yeah.
Thank you. James, you are in the, between suppliers and the clinicians, trying to, decarbonize in your facility. So how do you, from your perspective, how do you shift the internal culture? So the boards see decarbonization not as an extra task. We heard about return of investment earlier on business case, but then as a also key component of the strategy when you have to convince.
Yeah, you've got to make it business as usual. So it's got to be part of your organizational DNA. A few of the speakers have already mentioned that. It shouldn't be an add-on. So sustainable healthcare should be financially affordable. It should be amazing outcomes for patients, and it should be within the planetary boundaries to keep our life support system alive. So, it's pretty basic stuff. At Newcastle, we call that caring for people and planet. So if you've got a blue strand of a DNA, that's care, the NHS blue. We want to weave green thread through that DNA as well. So it just becomes normal, embedding it into your DNA. And that's a shout out to Annalisa Mills, a member of my team who came up with that. So I didn't. And we've made it an explicit priority in the trust strategy. So a lot of hard yards when you get these milestones of, 5-year cycles where you need to bed it in as a priority. That's hard. So, a lot of competing priorities. Johnny's articulated that really well. It's in there as a priority of our trust. So the board get that. They see value in that. So sustainable care is just how we do care at Newcastle. How that actually works is because the Green Champions, our staff, we've got 1,300 of them, they asked the CEO to do that. There was a letter in our Green Champions network that pushed the CEO to make it explicit priority, and then we had the hard work of trying to make that happen. But they empowered the CEO and us to make that happen.
So it is coming, when you say 300 of our staff, is this coming from the clinicians as well? So there's been already a culture shift.
Yes. So clinicians, admin assistants, healthcares, anyone in the hospital. So a lot of people who are passionate about caring for people and planet. But we've also embedded it just into processes. So, Sarah touched on that. How do we measure performance? Yeah. Clinical outcomes, financial, and how you're reducing the environmental impact. We haven't cracked it, but that is the plan. So if you're going to do good care, you need to do it with a lower environmental impact.
Okay, thank you. So looking ahead, your future vision for scaling net zero healthcare. I'm going to ask another question to Sarah. Thinking of the European landscape in the next 10 years, how do we move from islands of excellence? There are a lot of interesting projects, individual trusts, to a truly national model of net zero. And how can policy ensure decarbonization remains a priority, regardless of the political economic shifts we're seeing now? There is always another crisis, right? So how can we keep this sort of North Star and try to scale all these different interventions?
Well, to an extent, we're starting to do this here with this collaboration, this learning from each other, alignment. I think I feel like, for 5 years, every one of these conferences would start with, the impact of climate change on health. It almost feels like we don't do that anymore, but actually we still need to do that pretty much. And, on a week like this week, I really hope nothing will make the headlines, but, you were talking about overheating theater. Like, just reminding everyone of how immediate the threat is and how the impact is already happening, how it's affecting, the time you wait for your surgery, how it's affecting, your ability to attend A&E. So really making it a here and now problem for the population, because then, government follows what populations want. And so really making it obvious what the impact is, and that it's not like a long distance threat, like far in the future. So we need to continue to make this case and build on the evidence that we're accumulating year on year to make that case. And the other things in terms of, this is more the threat argument. If I look on the other side of the SWOT, like the opportunities, all of the co-benefits, I think we can make ourselves quite indispensable in looking, the Norwegian experience of including sustainability criteria in procurement actually shows that increased resilience. You increase transparency, you increase supply resilience. And at the moment, there's no health systems that has the luxury to not care about supply resilience with everything that's happening geopolitically in the world, showing how actually there is such a thing as like innovation as being seen as a leading country, as a leading health system, how it actually saves money. We've talked about prevention. I think, we've been trying to do public health and prevention for decades and decades. Well, maybe this is a new way to look at it. Maybe this is a new argument, a new way to engage people in this reflection. So the more we can maximize the wider benefits, the more indispensable like this conversation becomes, and the more it like sort of gets a bit in every conversation as we've been repeating just in this roundtable.
Okay, thank you. So perhaps emphasizing the need for preparedness and resilience and the benefits, the co-benefits, as you mentioned. And James, at Newcastle, you have led this work as we look to that future model that Sarah is describing. We will need to move beyond the low-hanging fruit and the easy, well, not always easy, but the easiest things that we can do. What is the one future technology or systemic shift that you believe will be the game changer for healthcare facilities? You talked earlier about energy.
Yeah, maybe it's be a killjoy, but I don't want to rely on technology. Mm-hmm. So, I think fundamentally it's all about people. So if we rely too much on tech, not to put you down too much, Oliver, it's a critical enabler fundamentally, and we'll get more and more, no doubt. But if we lose people, we lose the care aspect of healthcare. And I think that would be really worrying. So what gives me hope is the clinicians, the clinician voice. They're the most trusted voice. So when they care and we give them the tools and the ability, the capacity to be able to act, loads of examples you've heard today where clinicians have wanted to do it. They've been able to evaluate it through a quality improvement mechanism or such like, and then they've delivered on it. And then, yes, we have the challenge of scale, but what gives me hope going forward is definitely the clinical voice, and I believe they'll be the transformation that we need. Yeah,
and also, sometimes innovation is not a new product, but it's also a way of doing things. And that's very important also to remind ourselves. And so, hearing from the clinical perspective, Johnny, new technologies and models only work if people trust them. You mentioned earlier, about clinicians having to adapt their way of working on learning how to use a reusable laryngoscope. In your experience, how do we communicate to patients and other healthcare professionals that nausea is not a compromise? You mentioned a bit earlier, about quality of care. So how can we better communicate about a higher standard for care and health?
Yeah, I think we need to take a step back. I think we need to actually get good at communicating with patients about what this actually is. We can talk about climate until we're blue in the face. It's nebulous. People don't really get it. It's not landing. This is a cost of living crisis. This is a security crisis. And this is the single biggest public health threat facing humanity. And if you're a healthcare worker, when you were managing the last massive, acute public health crisis we faced, we got together, we acted at pace, we worked, we listened to the public. We need to take that same approach when challenging this. We need to upskill in climate literacy. We need to use this veracity that you've explained, James, to be able to understand that we are a trusted voice, but we should be using that voice way more effectively to get things done. So I direct something called the Tottenham Creative Climate Collaborative, and we work with communities trying to get them to become more climate literate, but mostly not to say, I need you to stop using plastic bags and turn off this. It's actually to get you to actually, represent yourself and speak truth to power about what you are facing as a community. We find creativity is a really good way to do it, because creative means the veins of creativity run through diverse communities, and we found that to be really effective. But what I've noticed in the communications that I've been having with community people in Tottenham, what I would call experts by experience, we've got people that are working really hard with respiratory physicians about their lung health. They don't want to be told that the most important thing they need to do is change their inhaler. Yes, that's an important thing we should all be doing. They want us as physicians to advocate for them. We need to be collecting the data that links that admission to high pollution levels. We need to be collecting this data as we speak to create the evidence base to speak truth to power. We're not doing it well enough.
Thank you. Thank you for sharing that. I have one last question, moving to Oliver. And so we heard, that if our systems succeed in net zero, they will need the industry to back them up and to also decarbonize. So how can healthcare facility and national health system better leverage the private sector innovation and expertise to decarbonize the supply chains?
Thank you. So innovation is something we're really proud of in medtech. I have nothing against pharma partners, but most pharma innovation is about discovering a new molecule at the end of the day and seeing if it has clinical utility. I'm being crude there, but in medtech, it's very different. You're able to play with a vast range of materials, techniques, digital tools, non-digital tools, etc., to innovate products. And as you said very rightly, to innovate processes and delivery. And in Europe in particular, we have a lot to be proud of, because some of the best innovations in healthcare actually came out of Europe. Things like minimally invasive surgery and the like. They don't always launched here first, but they were discovered here. The thing is, we have been innovating for over hundreds of years, basically, usually based on the feedback and requests of the physicians who use our devices. Most devices are not used by individual patients or laypersons, but by physicians and nurses. And we've innovated for patient care, for clinical care, but we now need to innovate for planetary care. And it's interesting, you follow a company through their sustainability journey. Before they come out the other end as trendsetters and visionary, proactive players, often in the very beginning, they look at this as a giant hassle, a giant problem. They say sustainability expectations are raising burden, they're raising cost, and we're not going to get paid a price premium, even if we do rise to that challenge. So quite frankly, this is a pain in the neck. When they come to a point of reframing it and saying it's not just a pain in the neck, but it's actually their innovation space, that's when the mentality shifts, budgets can unlock, CEOs can get activated. And that's what I see in some of the more advanced companies in this space. They are specifically innovating for planetary health because they recognize that that is actually the unmet need we should be innovating for. Yes, we have unmet patient needs, which we should keep innovating for, but now we need to start innovating for other ones too. So that framing is really, really important. And some of the framing needs to happen wherever the worldwide CEOs and executive committees are. They're not always based in Europe. Sometimes they're based in faraway continents to the west of here. But we can do that. And what would also help, of course, then is if we recognize that that's a valid form of innovation, how are we going to facilitate the uptake of that innovation? If you go to regulators like the MHRA in UK, FDA in US, what have you, they will often have dedicated regulatory pathways for innovation. If an innovation really does respond in a massive way to unmet clinical need, they will find ways to not lower the standards, but accelerate the approval timelines. But I'm not aware of any regulator that's currently doing that for innovation that responds to unmet planetary needs. That could perhaps be a conversation worth having if it's really a good way of recognizing that this is a need that is actually endorsed. And then I think you will see R&D teams and managements really pay attention to that and structure themselves accordingly.
Wonderful. Thank you for sharing this insight. And we do not have much time for questions. We have to move to the next plenary. But I encourage everyone in the networking session to go to our speakers and ask more questions and share, your work you're doing and identify opportunities for collaboration. But it was very, I would like to thank our speaker to share, a bit the challenges you're living, as well as your recommendation and vision for the future. Thank you so much. Please, a round of applause.